appreciate you coming out tonight. My name is Mike Jensen, and on behalf of Olathe Medical Center, I'd like to thank all of you for joining us here in person and also online. For those of you viewing it through our webinar, we appreciate you all joining us. This program is part of our ongoing community health education series, and so we appreciate you being a part of it. Before we get started, I have just a few quick things to go over. Tonight's event will last about 1 hour. Our speaker, Dr. Opie, will speak for about 30 minutes, and that'll leave plenty of time for questions and answers at the end. For those of you here with us in person, you should have received a folder, and within that folder there's a lot of information in there, but there is also a sheet for you to write your questions on. So that we keep it organized, especially with broadcasting online as well, we'll just ask you to write your questions down, and then we'll pick those up after Dr. Opie is presenting. For those of you online, you can go ahead and ask your questions at any time throughout the presentation, and we will print those off and bring them up to the speakers. Olathe Medical Center is proud to have the fantastic surgeons of Midwest Surgical Associates as part of our medical staff. The group is well established with a long history of excellent surgical care for people in our region. Dr. Harlan Opie is one of the 6 surgeons in the group. He and his partners have very busy general surgery practices, and Dr. Opie also specializes in weight loss surgery. He performs all 3 of the major weight loss surgeries available today, but I'll let him tell you about that. Again, thank you all for being here, and please welcome to the podium Dr. Harlan Opie.
Thank you, Mike. It's great to see all of you here this evening. Our goal this evening is to talk about what we've been doing here at Olathe Medical Center for the past 10 years with respect to weight loss surgery. We're going to talk a little bit about what kinds of surgery are available, who is eligible for the surgery, and what kind of results you would expect after having surgery. And then at the end, we're hopefully going to have around 20 to 25 minutes or so for questions. And Mike talked to you a little bit about those logistics, and we'll look forward to that as well. So some celebrity pictures here, some befores and afters. And why do these matter? Well, the reason that we put these up here have to do with the fact that weight loss surgery is mainstream. And the reason it's mainstream is because, number one, this is a serious medical issue, probably the most serious medical issue really affecting our country at this time, in the world, or at least Western civilization. And the second reason is because these pictures are up here because it works. And folks like this would not be putting themselves out there if this doesn't work. And there really is nothing out there that works better than surgery for the folks who need to lose serious amounts of weight. So what we want to do as we look at this is we want to try to get rid of some of the baggage. We want to get rid of some of the old perceptions of what it means to be seriously overweight, that somehow this is seen as some kind of a personality flaw or a weakness or a failure, your inability to just eat less and exercise. You probably heard that more times than you'd care to recount. Somehow that weight loss surgery is dangerous, extreme, radical, or that it's really the easy way out, that somehow people who choose surgery are really it's really for people who have a weak constitution. And what we all know is really that's the opposite of reality, in that you really have to have a lot of courage to confront this and consider surgery to treat the problem. And we want to see it for what it is, which is a disease. It is the cause of many serious health conditions. And it is really the only proven method to treat the disease significantly. We don't have any pills that will do this, and there aren't any pills in the pipeline that are going to make a significant impact on this disease, not like surgery. This is our mission statement, and it is in your packet. The thing that I think is important is that we're going to undertake this in a multidisciplinary setting. What does that mean? Well, it means that you need a good operation. If you don't get a good operation, then you're going to have troubles. But if all you get is a good operation, then you're going to have less success than you could have otherwise had. So what does it mean to be multidisciplinary? It means that, first of all, you're here. This is the point of entry into our program because you need education. You need a thorough medical screening, you need an operation, and then you need follow-up. And it's not onerous, but all of those pieces are very important. And if we do those, then we have a greater chance of durable success because that's what we're after. We're not after a 100-pound weight loss and then a 120-pound weight regain. We're after durable weight loss. And if we do these pieces, our chance of success is high. So let's talk a little bit about some definitions. First of all, body mass index, and it's just really a fancy ratio of height to weight. And you can see the international clinical classifications there in the middle, and we're going to really look at obesity 1, 2, and 3 for body mass index of 30, 35, and 40. And on the bottom there, you can see the breakdown of the percentage of population in each one of these areas. But we're talking about a significant number of folks. In terms of who is eligible for weight loss surgery, we're really looking at 3 groups. And so what I'm going to do is kind of start at the far right-hand side and talk about folks with body mass index of over 40. If you have a BMI of over 40, you have clinical eligibility for any bariatric surgery in the country right now. And we're going to talk a little bit about those things individually. But moving down to a body mass index of over 35, if you have a BMI of over 35 and you have other comorbidities, and you're going to hear that word comorbidities several times, what that really means is just other medical diseases that are a direct result of being overweight, then you would be eligible for surgery. There is a small subclass of folks with a BMI of over 30 who, if they have comorbidities, would be eligible for the lap band only. The FDA recently approved the lap band for BMIs of over 30 if you have comorbidities. It's my feeling that we're probably going to see the indications for at least gastric bypass move down as well, based on the Stampede trial where they did gastric bypasses on folks with BMIs as low as 27 for type 2 diabetes with high rates of cure of type 2 diabetes. So I think that's going to move down a little bit, but we aren't there yet. That's just my projection. I may be wrong. So this is a slide just showing a nomogram that just gives you a rough idea of body mass index. If you look at your height and your weight, you can kind of get a rough idea where you would be. The easiest way to really find out what your BMI is to go to Google and put in BMI calculator. You'll get a bazillion hits, and you can just put in your height and weight, and it'll give it to 3 decimal places, and then you'll know. Well, we're not just talking about cosmetic issues, people wanting to be thin. We're really talking about serious health implications. On the left side here, you see what happens to your relative mortality rate at any given age as your body mass index increases. So if you have a normal BMI, your mortality rate is what it is for any given age. As your body mass index goes up, by the time your body mass index is a 37 or a 38, your mortality rate is 200% or double for your age. And it triples by the time your BMI is around 42 or so. So we can reverse that, pull you back down the curve by durable weight loss. And of course, the mortality rate relates to many things, but mostly to the list of comorbidities on the right side of this slide. And those are listed there. This is not all inclusive, but these are the big ones. Diabetes, hypertension, sleep apnea, depression, significant joint pain. There are infertility issues, especially in women, certain kinds of cancer, including colon and prostate in men, and breast, ovarian, and colon in women. significant gastroesophageal reflux disease, asthma, and other things. And we've got another graphic here a little bit later that shows some more of these processes. Well, so what happens with durable weight loss and conversely being overweight? How much money do we anticipate that you would save in a year with durable weight loss? And this is some data from 2009. We had a slide here early on in our experience that had this number at around 15,000 from 2001 data. But you can see that you're going to spend less money on medications. You're going to have less employment and activity costs, so your boss is going to like that. You're not going to buy as much Jenny Craig. No knock on Jenny Craig, but you won't be doing that. You'll be buying less medications, and you'll be buying less food. And that sounds bad, except you'll be no more or less hungry than you are today. So you may have to put some of this money in your gas tank, but you will have more money being at a lower weight. This is a kind of busy slide, and you have a copy of it in your packet. But what it really does is it looks at what happens to given disease processes with durable weight loss. And so some of the ones I would like to highlight, if you start at the top and we kind of work our way down, if you look at sleep apnea, we have between a 75 and 98% resolution rate, and that happens early on, usually within the first 2 to 3 months. Folks are off their CPAP. If you move down, looking at hypertension, 70% get off their medications completely. Type 2 diabetes is cured 80 to 90% of the time, and that is especially true for gastric bypass. There is a little bit of timing involved there, such that if you've carried the diabetic diagnosis for 8 to 10 years, then we would have a less high expectation of a cure, but we should help your control. But if you've had your diabetes for less than 3 years, we have an excellent chance of making it go away. It just flat goes away. Stress urinary incontinence is well affected along with the osteoarthritis, although we don't do quite as well with those as we do with some of the others, mostly because some of the damage is already done and we can't reverse that damage. But we can make a joint replacement last the rest of your life instead of 10 years and then needing another one, for example. Gout goes away 70%, a high percentage of the time. If you have significant heartburn, we can do a really good job with that, especially with a gastric bypass. It's about a 98% cure for heartburn symptoms. Overall quality of life, 95% of patients say is better, and a significant reduction in mortality as well. So it's not just a cosmetic issue, and I realize that I'm preaching to the choir in a lot of ways on this. We're going to talk about different kinds of plumbing, different operations, when we use different ones and when they can be used somewhat interchangeably. We're going to talk about the gastric bypass, and these are kind of here chronologically in terms of what came along first. The lap band was next on the scene in terms of major surgeries that are done in this country at this time. The first one was done here in 2001. And the sleeve gastrectomy, which is the most recent addition to mainline bariatric surgery. And there are multiple studies out there with 7 and 10-year data, good durability success with the sleeve gastrectomy. So the gastric bypass is the gold standard. Everything gets compared to it. Your weight loss is either better or worse than the bypass. The operation is either a higher complication rate or lower complication rate than the bypass. So everything's compared to the bypass. And the weight loss is initial, or rather rapid initially, sorry. The laparoscopic approach is the norm. I've been doing these for over 10 years, and we did several open cases right at the very beginning because that's what was the recommendation. And we hadn't done an open case until about 4 months ago when we had to convert from a laparoscopic to an open operation because a patient had had really bad pancreatitis in the past, and we just technically couldn't do it. So we converted to open. Otherwise, the laparoscopic approach is the rule. We just don't do open bariatric surgery anymore. This operation has been around in one form or another since the 1980s. Some of the disadvantages, we have to do some intestinal rerouting. This puts us at some risk for some micronutrient deficiencies and some perioperative complications. Overall, very well tolerated. And we just have to watch some of your laboratory levels and various micronutrient levels long term, although the first 2 years are the most critical in that way. The lab band, like I mentioned, has been around since 2001, and it has a very safe 30-day complication rate, probably the lowest of all 3 operations. It is reversible in the circumstance where we would want to do that. There's a very low risk of malnutrition or micronutrient deficiency. Some of the disadvantages, you've got to come back and see me more frequently. It does require an implanted medical device, although there's never been a recall. The weight loss is significantly slower. And something that we've learned here within the past 2 to 3 years, which has caused a decrease, a significant decrease in the number of bands that are placed, is that it has the highest overall reoperation rate after 30 days. It has to do with failures in the band. It has to do with some unrecognized complications of having the band in long term that were not initially appreciated, that make the band not useful for weight loss and cause people to have symptoms where the band needs to be removed because their quality of life is just so poor. The last operation is a sleeve gastrectomy, and essentially what happens in this circumstance is that the stomach is taken from the size of a small youth football to a long skinny tube that would be close to about a 5/8 inch garden hose, if you can think of that in your mind. And we remove the outer part of the stomach. You can see the graphic there with a portion of the stomach that's removed there. So that does 2 things. It limits your capacity to eat. You have a very small functional pouch area right at the top of the sleeve. But more importantly, it removes the fundus of the stomach, which is the upper part of the stomach there. And we think that that is probably why this operation works well. It has a lower risk statistically in terms of perioperative complications than the bypass, with very similar weight loss. The only thing that perhaps the sleeve is less good at than the bypass is with respect to treating people who've had diabetes. The bypass is a better diabetes operation, clearly, especially if you've carried the diagnosis for 2 or 3 years. If you've just been diagnosed, every once in a while someone will come in and they were just been diagnosed with diabetes, and that's what gets their attention. That's why they're here. They're scared about diabetes. Their mom had diabetes. Their uncle had diabetes. They know what happens to you if you have diabetes for a long time, and that's why they're here. In that case, the sleeve and the bypass are similar in terms of their ability to reverse diabetes. Well, let's talk a little bit about risks and complications, because we've talked about what our goals are. We've talked, and we're going to speak about what the expected weight loss is. But let's talk a little bit about the downside. I heard a radio commercial for bariatric surgery, and at the very end, the person that was giving their testimonial said, just go ahead and do it. There's nothing to lose. Well, it's like anything in life. There's risk and benefit in everything, right? So part of the educational piece of this is for me to tell you what the risks are. And we've had no deaths in our program in 10 years of doing this. And our complication rates are lower or no higher than any published complication rates out there with respect to the operations that we perform. So if you look at lap band, sleeve, gastrectomy, gastric bypass, you can see that the total complication rates, and these are in the first 30 days. You can see that the band has very low complication rates, the sleeve is in the middle, and overall complication rates for the bypass are 10%. Major complications, these are the ones that put you in the ICU for a week and a half, and maybe you stay in the hospital 2 or 3 weeks. 1%, 2%, 2.5%, sleeve and the bypass are very similar. Mortality rates are very low, but we still quote a mortality rate in our informed consent phase of 0.5%, because that's generally what's the published rates, even though we've had no deaths in our program to date. and that would certainly be our goal. Many published series out there, thousands of patients with no deaths, so it is doable. It is a possible goal. But there are risks with this operation, all these operations. It's not zero, and if someone tries to tell you it is zero, then they're not being completely honest with you. Well, here are some of the complications, and this is related to the lap band. These things here can cause the band to need to be either removed or revised. You can have a slip. The band can erode into the stomach. You can have esophageal dilatation, and this is the one that we really didn't appreciate as well early on. The esophagus dilates. It becomes a kind of a non-functional just pipe. It isn't able to do its job of moving food downstream, and people have really bad reflux symptoms related to that. You can get dilatation of the pouch, which is the little part of the stomach above the band. Some folks have very severe disabling reflux such that they can't have any volume in the band, and therefore it doesn't work. You can have a band tubing break, which is not hard to fix, but it still takes an operation to do it. You can have a port flip, and you can have pain related to the port site. So those are some of the list of complications with respect to the band. With respect to gastric bypass, again, you see an operative mortality rate of 1% to 0.5%, like I said earlier, and this kind of breaks it down. The big one, the big concerning complication is a possibility of an anastomotic leak. When surgeons start doing this, they see anastomotic leaks at the beginning of their career more than the end. And that has been the case in our circumstance. We have a much, much lower leak rate now than we did 10 years ago. And some of the other complications are listed there. One of the things that can happen long term is you can have small bowel obstructions, and those are related to how the operation is done and how the intestine is rerouted. These are some of the late complications for gastric bypass. You see some of the iron and vitamin B12 deficiencies, calcium, and we talked about bowel obstructions. Hernias are very rare in the laparoscopic age, and rarely excess weight loss can occur. Sleeve gastrectomy, the main concern in this case is that long staple line, and you can see the leak rates published there. If you have a leak, that can make you pretty sick. We have yet to see one of those. You can get stricturing. What does that mean? It just means that the sleeve itself just scars down, and it takes intervention to open that. You can have delayed leaks. We do see our sleeve patients early on experiencing dehydration. They just can't get enough fluid in right after surgery, so what happens, we check on them frequently, we find out how they're doing. If they get dehydrated, they just pop in, they get a couple of liters of IV fluid, and they go home, and that usually goes away in a week or so. We do that rather than let people get really far behind. Then they get so sick they got to come into the hospital for a few days. So we're real proactive with that piece of it. Recovery time, you can see here, we still keep our banders overnight, and we keep our bypassers and sleeve patients till 2 days post-op. Usually they go home on the morning of post-op day 2. It takes about a week versus 2 weeks to get back to normal activity, and people consider themselves fully recovered in 2 weeks and around 3 weeks respectively. I've had bypassers go back to work, people that own their own business, for example. They're working on post-op day 1 on their laptop in the hospital. So how much and how quickly you go back to work is a function of necessity. So why do we choose any given operation? Well, most folks come in with a preference. They know what they want. They've had a friend who's either done very well or very poorly with any given operation. And so they have their preference. And it's not my task or job to dissuade you from that, to say you can't have a this or you can't have a that. My job, and it begins here tonight, is to help educate you on what's going to be the best for you, and so that we can do the right thing. If someone comes in and they tell me, I'm getting a this, and if you don't do it for me, I'm going up the street. If that may not be the best thing, but that's what they want, then I'm not going to make them go up the street. Having said that, if you've got a diabetes diagnosis for 6 years and you're on 4 oral agents and insulin and you want a lap band, I'm going to have a hard time doing that for you, because that is just going to be C- treatment for what you need. Do you have reflux? Do you have GERD? Because this is a big thing. GERD is very common in a lot of folks, but especially in overweight folks. Why do you have GERD? Well, most people have it just because of their weight, and they lose their weight and it goes away. But do you have a significant hiatal hernia? What is that? That just means where your esophagus comes through your diaphragm. Is your stomach sliding up in your chest? If you have a small hiatal hernia, it doesn't matter. If you've got a bigger hiatal hernia, then there are certain operations that are going to be better than others. And I would not put a band in you, because it will never work and we'll have to take it out. A sleeve might not be the best choice for you if you have significant heartburn. If you have Barrett's esophagus, for example, which can be a pre-malignant condition for esophagus cancer, a sleeve is probably not the best thing, because if you ever needed to have your esophagus removed, we'd really like to have your stomach there, your old stomach, to use. So little things like that, and so we just collaborate on that. We really want to talk about GERD and make sure that we're making the right choice with respect to that. What are your risk tolerance? Some people are going to come in and they tell me, I'm only getting a band because it's the safest short term. Even though it has the highest reoperation rate long term, they'll take that. It's not my job to tell you what your risk tolerance is. That's something that is there as part of you. With respect to the sleeve gastrectomy, it is currently increasing in market share, and the reason has to do with the lower risk, very similar weight loss to a gastric bypass, but less micronutrient issues, lower reoperation rate, and it can be converted to a bypass in the future if for some reason your weight loss is suboptimal. So in my opinion right now, all things being equal, I think the sleeve gastrectomy is the best choice in terms of the risk-benefit, provided you don't have diabetes. That's where I think we are right now. Where we'll be in another 5 years, we'll just have to see. But in 2014, that's where I think we are right now. What does the weight loss look like? You can see the weight loss curves here, and the takeaway is that the band is going to end up somewhere around 50% excess weight loss, and the sleeve and the bypass are going to be durable at somewhere around between 65 and 70%. This slide shows about 75%. It's in the ballpark. You can see what the speed of weight loss is. The bypass is the fastest. The band is the slowest. But this just gives you an idea of the relative excess weight loss. So how do you decide what you're going to do? And this is a pretty busy slide. But you really need to look at all of the factors, not just necessarily how an acquaintance of yours did, although it's impossible to divorce yourself from those thoughts, good and bad. Diabetes is a big thing. The bypass is the best diabetes operation, and I think that's pretty clear. Other things being equal, I think the sleeve represents a great risk-benefit trade. And it does have durable data out there, so it's reliable in that way. A little bit of show and tell, a little bit of before and after. These are some old pictures of some band folks. Our very first gastric bypass patient back from 2003, I should say our first laparoscopic. We did do some open surgery before we started doing laparoscopic patients. Here you can see a body mass index of 47, medical issues including type 2 diabetes, hypertension, sleep apnea. And there you can see Kathy's medications. December 2003, currently her BMI runs between 25 and 28. She is on no medications. Hemoglobin A1C is normal. And here's the after. Here's Cheryl. Here's Cheryl's numbers: BMI 45 before surgery, hypertension, sleep apnea, asthma, gout, significant reflux, and there you can see her medications. We actually did her 2 weeks before, so I guess Cheryl would be technically our first laparoscopic patient, but they were all there within a couple of weeks. Her BMI is in the mid to upper 20s. Her gout went away. All she takes is her vitamins, and she's doing quite well. So why choose our program? I've been here at Olathe Med for 17 years now. We've been doing bariatric surgery for 10 of those years. Follow-up is important. You still see me every time you come to the office. I do the band fills. I see you every time you come in. Melissa is heavily involved as well, but I'm not going to have you seeing my PA or whoever. We have a lower volume of patients. What does that mean? I mean, that sounds bad, right? Well, no, not really, because you're not one of the multitudes. You're not one of hundreds or thousands of patients. You're one of 40 to 50 patients a year. We perform this operation in a hospital setting. If you were to need the assistance of pulmonary doctors, heart doctors, infectious disease doctors, they're all right there. We don't have to put you in an ambulance and send you to a real hospital. You're in a hospital setting. And lastly, talk to our patients. How do you get access to our patients? The easiest way is to just go to support group. And there's a support group schedule, I believe, in your folder. But it is the first Thursday of the month, fourth Thursday of the month. Melissa is there. We have guest speakers that come in, talk about nutritional issues, counseling issues, all kinds of pieces of the multidisciplinary effort. We have all kinds of folks from bariatric programs all over the city coming to our support group. It's a real friendly place. How do you make this happen? Well, the first thing to look at is to look at your insurance benefits, and you really need to see this in writing. You need to get a copy of your policy. If you call the helpline, there's a decent chance that you may get some inaccurate information. They may tell you you have benefits when you don't. I promise you that there is a written copy of your policy, so find that, and I guarantee you that bariatric surgery is addressed. Let's say that you don't have benefits. You can pay for this yourself, and our personal pay or direct pay option is $16,000. That is not the cheapest in town. It's not the most expensive in town. It doesn't include 2 days here in the hospital. You won't be sitting at home 3 hours post-op in your living room with your sleeve gastrectomy wondering, what do I do now? And how do I make this pain go away? And my heart seems like it's going really fast. I wonder if it's too fast, kind of thing, okay? You're here for 2 days, so I've yet to have anybody tell me, gosh, you know, I really hated my 2-day hospitalization. I really hated my pain medicine. I really hated people coming and taking care of me when I rang my button. So that's a good thing. People have all kinds of imaginative ways that they think of to take care of the financial aspect of things. And I'm not an accountant, so I can't tell you much more than's up there right now. But taking the next step, this is, like I mentioned, the entry into our program. This is the first step, the educational step. And so the next thing to do, if you want to take the next step, is you call the office for a consultation. It doesn't take too long to get in usually. And at that point, then you and I sit down and we talk about, what do you want to do? What your goals are? Why are you doing this? And it's not like there are wrong answers when we talk about those things. But we want to make sure that we're all on the same page and that your expectations are accurate so that you can have a durability and success long term, because that's really what it's all about. And so with that, what I would like to do is we will have Melissa read us some questions, and we'll answer those for the next 20 minutes or so.
So for you at home, for those of you at home, please submit your online questions now. For those of you in the audience, if you would pass them to the outside aisle to be picked up. All right, so the first question, how long can I expect to be off work after a lap band, gastric bypass, and sleeve surgery?
Most band patients take around a week off, sometimes less. And about the fastest you would go back after a bypass or a sleeve would be 7 to 10 days. Most sleeve and bypass patients take a couple of weeks off, and sometimes longer. It depends on how badly they need to get back to work. If they've got the paid sick time, sometimes they take a little longer. If they run their own business, like I said, they're back pretty quickly sometimes.
Why do you only do 40 to 50 patients per year? Is this normal, or do you choose and select individuals? So may I be turned away?
That's a good question. In 10 years, I think that I have refused to do 2 patients based on psychiatric profiles. The reason that I only do 40 to 50 cases a year is because I enjoy doing other kinds of advanced laparoscopic surgery and other types of general surgery. And it's important to keep your skills up. And we do bariatric surgery on Mondays, and that allows us to have a full week in the hospital to recover. And so that's why we just choose to do that many. We could do more, probably, but that's why.
Are there any more complications or less success with the sleeve for somebody who has had their gallbladder removed and has hypothyroidism with 1 thyroid removed?
Neither one of those pre-existing circumstances, having had your gallbladder out or having had thyroid surgery, we would assume that you're on appropriate replacement of your thyroid medication so that you have appropriate levels of thyroid hormone in your system. But otherwise, the sleeve is a fine operation in those circumstances, no less than any of the other operations.
Will most insurances cover surgery?
Good question. That is changing all the time, although it is better now than it once was. We see the state of Kansas recently made this a benefit for all state employees due to some hard work of a bariatric surgery friend of mine that lives in Topeka. And it is becoming more mainstream. That said, some types of insurance do not cover some types of operations for reasons that I don't completely understand. But it is becoming more commonplace because they get the really bottom line financial piece. They make their money back in a little over 2.5 years when they buy a bariatric surgery in most cases. So it is becoming more commonplace, but again, you just have to check your policy to find out, and you got to see it in writing.
What happens if you get the sleeve and later in life you get esophageal cancer?
Great question. If that were to happen, the option for you would need to get your esophagus out, just like anybody else with esophagus cancer. The question would be, how would you reconstruct the tube between the back of your throat and your lower GI tract? And in that case, the really only option, well, 2 options, but the main one would be to use a piece of your colon to do that. That is suboptimal. And that is one of the reasons why I perform an upper endoscopy on all of the patients that we are going to do surgery on. I do the scope myself. If you have any perioperative complications that require upper endoscopy, I do that as well. I'm not going to ship you off to a gastroenterologist to have him do something that he's completely uncomfortable with. I take care of all of that myself, such that if you had a significant esophagitis, meaning you had significant gastroesophageal reflux, or if you had Barrett's esophagus, which is the pre-malignant condition, we would not do a sleeve on you because we would not want to be faced with the circumstance of, if you were one of the 4% of people with Barrett's esophagus that got esophagus cancer, we want to be able to cure your esophagus cancer and leave you with some kind of a good functional tube, and the stomach would make a far better one than the colon. Now, if this just came out of the blue, and you just got an esophagus cancer after 15 or 20 years, and you'd had a sleeve, then you would be stuck with a colon interposition, which can be done. It's just not as good for you physiologically.
What is an anastomotic leak and the complication due to it?
The word anastomosis is just the fancy surgeon jargon for when we connect two hollow viscera together or two blood vessels. So it just means the connection. And what that refers to is when you have the little pouch, you got a gastric bypass, you have the little pouch, you bring the intestine up, you hook that to the pouch, that's an anastomosis. So that has to heal. And if it doesn't heal, then the saliva and whatever else you eat leaks out of there, and that's a bad problem. Just like if you had a colon resection and you put the colon back together and that leaks, that's a problem because you have what you eat leaking out into your abdomen. So significant infection, and it's caused by a number, sometimes it's caused by technical errors, although those are much less common after you get through the first year or two of doing this. It's caused by factors that we don't completely understand. It can be caused by people who smoke, and factors that we don't completely, we don't always know why there is a leak. We treat them by just draining the infection, putting you on antibiotics, and stopping you from eating till things heal. It's the usual course is we don't have to reoperate on you when you have a leak, but you can get pretty sick from it.
How do you maintain muscle with diminished intake of protein?
You really don't have a significantly decreased protein intake. We encourage people to get at least 60 and up to 70 grams in a day, which is about what you get now. We always emphasize protein first because you have a limited intake, so you want to get what's important first. Sleeve and bypass patients tend to have problems with carbohydrate, meaning if you ate a donut, it would probably make you feel bad because it would just whistle through your intestine. We get what you call dumping syndrome, and you just feel poorly. So there really isn't a problem with lean muscle mass. The other way we control the loss of lean muscle mass is with an exercise program, not anything that's just crazy, but it's important to have regular, reasonable amounts of exercise to maintain your lean muscle mass.
What levels of activity can be enjoyed after surgery?
It's kind of like the patient that asked me, "Doc, can I play the piano after surgery?" And I'm like, "Sure." And he goes, "Well, that's great because I can't do it now." So if you were not skydiving before your bariatric surgery and you decide you want to start skydiving, that's okay. There's really nothing you can't do with any of these operations, including the band. There was some early theoretical concern that maybe you couldn't scuba dive with the band because it would expand and cause you problems at depth, but you can scuba dive, you can bungee jump, you can jump out of perfectly good airplanes, and you can run ultra marathons, anything else you really want to do.
If you haven't had a diabetes diagnosis for very long, is the sleeve still an option?
The question was if you haven't had diabetes very long.
Mm-hmm.
Yes, I kind of mentioned that briefly earlier, but if someone has just been diagnosed with diabetes 3 months, 6 months ago, a year, I think that you can have a very equivalent resolution of diabetes with a sleeve or a bypass. The place where the bypass is better is with a diagnosis of 2 years, 3 years, 4 years, 6 years. Type 2 diabetes. It's real clear that the bypass is the better operation.
How is excess skin treated during and after weight loss?
That is a worry that a lot of folks have, and a couple of things. The amount of excess skin you're going to have relates to a couple of things. How much weight do you have to lose, and how old are you? If you're in your 20s, you're going to do better at that than you are if you're in your 50s, and that's probably not a surprise to anybody. If you've got 85 pounds to lose, you're going to do better than someone that has 185 pounds to lose. In many cases, nothing has to be done. Men tend to have a little easier time with it than women because men carry their weight inside their abdomen where their organs are. So the excess skin you see and the excess flesh is not there right now between the abdominal wall and the skin, so you're not going to see it, and that's just kind of a general rule. You can have all kinds of plastic surgery to have that skin removed, or just have minimal amounts to help you deal with the part that's a nuisance to you. We ask patients to wait a couple of years before they have plastic surgery, and the reason for that is that it really takes that long for your weight loss to occur and then your skin to bounce back, and it will bounce back some, more when you're young than when you're older. But you really don't want to go have an operation when you're 1 year out and then have your skin change and then have to go have another operation. Plastic surgeons are happy to do that for you, but we really like people to wait a couple of years.
Is there such a thing as obesity 4?
The short answer is I don't know the answer to that question. We do have older classifications where we talk about obese, super obese, mega obese. There's all kinds of nomenclature out there. But when we talk about folks when their BMIs get up in the 60 and 70 range, that is a extremely high-risk population of folks. But the obesity 3 is the classification of BMI over 40. And if there's an obesity 4, I don't know about it, but that doesn't mean it doesn't exist.
Does Weight Watchers count as trying to lose weight or a weight loss program?
That's a good question. Short answer is maybe. The insurance company is going to require that you have a 6-month medically supervised weight loss, sometimes 3, sometimes they don't require that. But what that means is that you need to have a medically supervised weight loss. Well, what is that? That means you go in to see a doc once a month, you get weighed, he counsels you, she counsels you on the importance of durable weight loss, and then you have a plan, and that all gets documented. Well, what is that plan? Well, that plan may be exercising at the Y 3 days a week and going to Jenny Craig. If that's the plan and it's under the supervision of your primary care doc, then that's medically supervised weight loss. But if you go to Jenny Craig on your own and you go to the Y 3 days a week and it's not under his supervision, then it doesn't count as medically supervised weight loss, even though it's the same thing. The whole goal, the purpose in most circumstances of requiring 6 months of medically supervised weight loss is that your insurance company wants to have you prove that you can follow through. And I think if you were going to write the check for someone else's operation, you'd want to know that patient's going to come back when the doc wants them to come back. They're not just going to disappear because they know that you're going to do better long term if you follow up. And they're really in this for the durable, they're not in this to pay for your operation. They're in this to pay for your operation and then see a return on their investment in 2.5 years when they break even on you. That's what it's all about.
Is there an age restriction?
Good question. Our upper limit is 60. Our lower limit is 18.
When can you begin exercising, and is there an exercise program?
We ask patients, they can begin walking whenever they want to, and as much as they want to walk. We have early on, and when I say early on, I mean a week, 2 weeks out, 3 weeks out, have discouraged really formal exercise programs because we've had some patients, very well-meaning in the past, who went straight home from their surgery and post-operative day 5, they were on the treadmill. And then post-operative day 10, they call me and they're so tired they can't get out of bed. Well, what do I think? I think, well, they've had some catastrophic complication, they're so sick they can't move, and what really happened is they just got on their treadmill before they should. So what we do is we ask people to walk. I gave a guy a permission that has really bad knees. He's 2 weeks out. I gave him permission to start doing a little swimming 2 weeks out. But most of the time I want people to not do any exercise for the first 6 weeks. At 6 weeks, and we try and get people primed for this. They come back at their 2-week visit, and I tell them I'm going to see you back in a month. At that time, this is what's going to happen. And one of the things that's going to happen is that we're going to start, and I will want a plan from you on what your plans are for 5 days a week of exercise. And what I'm talking about is about an hour a day where you get your heart up around 120, 130 for 40 minutes or so. Okay, and what we know is that that really helps us take advantage of the metabolic effects of the surgery, and it drives your weight lower than it will ever go, exercise versus no exercise. In terms of do we have any weight loss or exercise program formally available, what we have is a really nice cooperation with the YMCA that's here on campus, and they have bariatric recommendations and groups that you can do. We really like water aerobics. Why that? Like the worst thing in the world would be getting in a swimsuit, right? Well, turns out that you can do this in sweats. They have a zero entry pool. What that means is that there's a ramp that's really wide enough to roll a gurney down, because they do that too. People who can't walk, they roll them down a gurney into the pool. They have family dressing rooms. You can go in completely privately, close the door, get dressed, put on your swimsuits and put your sweats over it and go do water aerobics. And that's really good, especially if you have bad joints, knees and hips, until you've dropped, 60, 70, 80 pounds and your joints start feeling better. They have recumbent bikes that'll hold people over 400 pounds, which is really good because that doesn't beat your joints. So those are some of the things we do, but for those of you that don't know about YMCAs, they're probably about the best value out there for your healthcare dollar if you don't want to do it in your basement in front of the TV or, on a treadmill or a bike or whatever at home.
Well, I think that wraps up our questions. I want to thank everyone for coming tonight and joining us on the web. For those on the web, if you are interested in making an appointment or learning more information, you can contact me, and my number is 913-764-2350.
Thanks, everybody. Have a good night.